Assalamu alaikum. It's a long gone. I haven't made any video. Today I would like to discuss about a case called MND. What does MND means? MND actually means motor neuron disease. In MND, the chief complaint would be weakness and inability to walk for 2 months, weight loss and wasting of the limbs for same duration, occasional twitching of the muscle of the same for same duration. So weakness and inability to walk for about 2 months, weight loss and weight loss and wasting of limbs for same duration, and occasional twitching for same duration. So, according to the history of the patient, he was reasonably well 2 months back. Since then, he was suffering from weakness. He was suffering from generalized weakness, which is progressively increasing. This word is very important, which is progressively increasing for the last few weeks, which is progressively increasing for last few weeks, and he is unable to walk without the help of others. He is unable to walk without the help of others. The patient also complains of weight loss, which is not associated with uh, excessive sweating, polyuria, excessive sweating, excessive thirst, polyuria, cough, or diarrhea. For the last month, for the last month, he noticed progressive wasting of the lower limb. For the last month, he noticed progressive wasting of the lower limb, initially followed by the muscles of the hands and the forearms. Initially followed by the muscles of the hands and forearms. The patient also experienced occasional twitching movement of the different parts of the body associated with muscle cramp. His bowel and bladder habit is normal. His bowel and bladder habit is normal. He denies any history of difficulty in deglutition. He is denying any history of nasal regurgitation. There is no loss of sensation in any part of the body. So sensory is intact. There is no loss of sensation in any part of the body. In past illness, in there is no significant past history. Social, he comes of a middle class family. There is no significant family history. Patient is not taking any sort of drugs still now. On general examination, patient is emaciated and anxious looking. There is no anemia, jaundice, cyanosis, clubbing, koilonychia, leukemia, lymph node not enlarged, neck vein not engorged, and there is no hydromegaly. Pulse is 90 per minute, blood pressure is 150 by 80 per minute. On systemic examination, first of all, the most important is nervous system. In nervous system, there is higher psychic function. Higher psychic function include Higher psychic function, including memory, is normal. Cranial nerve is intact. In motor system, there is wasting of all muscles of the lower limb. There is wasting of all muscles of the lower limb of both hands and forearm. Muscle tone is increased in both lower limb. Muscle tone is increased in both lower limb and normal in upper limb. Muscle power is diminished in both lower limb. Muscle power is diminished in the both lower limb. Grade 4 by 5 also in the upper limb. 3 by 5 also in the small muscles of the hands are weak. In reflexes, in jerk, biceps, triceps, supinator jerk are diminished on both sides of the hand, and knee jerk, ankle jerk is exaggerated in both limbs, and plantar is extensor bilateral. So in upper limb there is lower motor neuron type of paralysis, and in lower limb there is upper motor neuron type of paralysis. There is patellar and ankle clonus. Coordination is impaired due to weakness of the muscle. Coordination is impaired due to weakness of the muscle. In involuntary movement, uh, muscle fasciculation in both muscle fasciculation in both thigh muscle and few in the upper limbs. Sensory is intact. Gait, there is spastic gait. In salient feature, uh, Mr. OFP, 45-year-old businessman, normotensive, non-diabetic, non-smoker, hailing from Comilla, presented with generalized weakness for 2 months, which is progressively increasing. Generalized weakness for 2 months, which is progressively increasing for the last few weeks, and he is unable to walk. He is unable to walk without the help of others. He also complains of weight loss, which is associated with excessive sweating, which is not associated with excessive sweating, polyuria, excessive thirst, cough, and diarrhea. For the last for the last 2 months, he noticed there is progressive wasting of the lower limb initially, followed by muscles of the hands and the forearms. The patient also experienced spontaneous twitching movement of the different parts, spontaneous twitching movement of the different parts of the body, which is associated with muscle cramps. His bowel and bladder habits are normal. He denies of any history of deglutition, nasal regurgitation. There is no loss of sensation in any parts of the body. He was treated with multiple vitamins by the local physicians. There is no such illness in his family. General examination and systemic examination is as previous. So I have some differentials. As the patient has lower motor neuron type of lesion in the upper limb and upper motor neuron type of lesion in the lower limb, and there is no sensory loss. There is no sensory loss, and the bowel and bladder habit is normal. Bowel and bladder habit is normal. So my one of the differential is motor neuron disease, most probably amyotrophic lateral sclerosis. In motor neuron disease, there is wasting of the muscle. So in here there is wasting of the muscle. There is no sensory loss. but the jerk is exaggerated and there is fasciculation also present. So in MND there is upper motor neuron sign, lower motor neuron sign. Upper motor neuron sign means knee jerk, ankle jerk, exaggerated, and plantar is extensor, and lower motor neuron lesion means there is wasting of the muscle and fasciculation, and there is no sensory loss, no bowel and bladder involvement. So one of my differential is motor neuron disease. Why amyotrophic lateral sclerosis? There is lower motor neuron sign in the upper limb and upper motor neuron sign in the lower limb, and amyotrophic lateral sclerosis. Amyotrophy means muscle atrophy, and lateral sclerosis means lesion. Lateral sclerosis means lesion in the corticospinal tract. Lesion in the corticospinal tract. So that's why uh, amyotrophy means muscle atrophy, and lateral sclerosis means lesion in the corticospinal tract. So that's why it is amyotrophic lateral sclerosis. Mention one common differential diagnosis to be excluded in such cases. Cervical cord compression involving C5 and C6 may be present with lower motor neuron sign in the upper limb and upper motor neuron sign in the lower limb. In such cases, MRI of the cervical spine should be done. In cervical cord compression involving C5 and 6, there is lower motor neuron sign in the upper limb and upper motor neuron sign in the lower limb. What are the differentials in such cases? There may be diabetes, there may be syphilitic amyotrophy, there may be other form of lesion. Okay, in motor neuron disease, what are my differentials? In motor neuron disease, my first differential is cervical cord compression or cervical myeloradiculopathy. Cord compression. What are the points in favor and points in against? In favor and points in against. In cervical myeloradiculopathy, there is progressive weakness. There is progressive weakness and muscle wasting of all four limbs. It is points in favor. All deep tendon reflex are exaggerated. This is also in favor. Bilateral plantar extensor, bilateral Hoffman is positive in cervical myeloradiculopathy. But in cervical myeloradiculopathy, points against is no neck pain, no history of trauma. There is sensory is intact in cervical cord compression. If cervical cord compression, there are other differentials like trauma, TB, tumor. There is no history of tuberculosis. Patient does not give any history of TB. There is no definitive sensory level. We know that in cervical myeloradiculopathy there is definitive sensory level. So these are my differentials. So one of my differential is this. Second one is my second differential is syringomyelia. We know that in syringomyelia, a points in a fiber is there is there is wasting of the upper limb. There is wasting of the upper limb muscle, and points in against is loss of pain temperature. But in here in MND there is no loss of pain temperature. There is difficulty. Gait problem is both cases, but in syringomyelia there is dissociative sensory loss. There is dissociative sensory loss. My another differential is multifocal motor neuropathy. In multifocal motor neuropathy, there is weakness and wasting of the limb muscle, and sensory is intact. But in multifocal motor neuropathy, all deep tendon reflex are exaggerated and increased muscle tone. This is points against. In multifocal motor neuropathy, all deep tendon reflex are exaggerated and increase muscle tone. In paraneoplastic syndrome, points in favor is wasting of the limbs and weight loss, but points against is no history of fever, cough, night sweat, weight loss. Fever, cough, night sweat, weight loss. Paraneoplastic syndrome most commonly is bronchial carcinoma. Most commonly is bronchial carcinoma. So we'll do the investigation. MRI of the spine, MRI of the dorsal lumbar, MRI of the cervical spine, and X-ray of the cervical spine, chest X-ray, bronchoscopy guided biopsy to look for bronchial carcinoma, bronchoscopy guided or carcinoma. So there are some certain no in MND, no sphincter disturbance, no sensory involvement, no sphincter development, no sensory, no dementia, no ocular, no cerebellar, no or extrapyramidal lesion. Motor neuron disease, characterized by degeneration of the motor neurons in the spinal cord, cranial nerve, and pyramidal neuron in the motor cortex. It's a degeneration of the motor neurons in the spinal cord, cranial nerve nuclei, and pyramidal neuron in the motor cortex. It is rarely happens below 30. Male are affected than female. Pseudobulbar palsy may happen in case of female. It may be there is familial. It is autosomal dominant familial. There is glutamate toxicity can be implicated in ALS. In pathology, there is degeneration of the bed cell, pyramidal tract, and cranial nerve nuclei, and anterior horn cell. What are the type of MND? According to the lesion, spinal cord and cerebral lesion. In spinal cord progressive muscular atrophy, there is lower motor neurons and amyotrophic, both upper and lower motor. Primary lateral sclerosis, lateral cortical spinal, that means upper motor neuron. In cerebral progressive bulbar and pseudobulbar pulse. Progressive bulbar pulse medullary lesion and pseudobulbar is cortical lesion. Pure human is progressive lateral sclerosis. Pure lower motor is progressive muscular atrophy. Progressive lateral sclerosis and pseudobulbar palsy. And human pure lower motor is progressive muscular atrophy and bulbar palsy. Pure lower motor is bulbar palsy and mixed is ALS. In bulbar palsy, there is dysphagia, dysarthria, and dysphonia. Tongue is wasted. There is palatal palsy. In pseudobulbar palsy, there is nasal slur speech, high speech, Donald Duck or hot potato dysarthria due to tight immobile tongue. Pseudobulbar is upper motor and bulbar is lower motor, and pseudobulbar jaw jerk is exaggerated. Pseudobulbar palsy, jaw jerk is exaggerated. Progressive lateral sclerosis, this is also upper motor neuron. Pseudobulbar palsy, Donald duck or hot potato dysarthria. Jaw jerk is exaggerated. Gag reflex is present. So if I want to differentiate between bulbar pulse and pseudobulbar, bulbar pulse is lower motor, pseudobulbar is upper motor. Bulbar pulse is the bulb of the medulla oblongata, and pseudobulbar is bilateral and internal capsule. In bulbar nasal speech, tonal duct or hot potato, pseudobulbar is slow, slurred, indistinct. Nasal regurgitation in bulbar, nasal regurgitation present, tongue is wasted, jaw jerk exaggerated, there is emotional, is normal. And pseudobulbar speech is a slow, slurred speech. There is no nasal regurgitation, tongue is small, stiff, spastic, jaw jerk, brisk. And emotion is labile. Emotion is labile. And treat MND, physical rehabilitation, psychological support, occupational rehabilitation, nutritional care. You should do percutaneous endoscopy, gastrostomy, high calorie food supplement, speech and communication therapy, respiratory, non-invasive, positive pressure ventilation, home and hospice care, end of palliative care, supportive fatigue for fatigue, paradigm amounted in depression, SSR, emotional lability, there is cramp, vitamin E, clonazepam, fasciculation, carbamazepine, spasticity, baclofen, salvia, scopolamine, joint pain, NSAID, insomnia, zolpidem, respiratory failure, bronchodilator, neuroprotective, riluzole, in IGF, riluzole glutamate antagonist, vitamin E, coenzyme Q, neuroprotectives. Cause of death in MND is bronchopneumonia, respiratory failure, and complication of immobility. Cause of death for MND is bronchopneumonia, respiratory failure, and complication of immobility. What are the causes of small wasting of the small muscle of the hand? MND, syringomyelia, Charcot-Marie tooth disease, cervical spondylosis, cervical rib tumor, myopathy, peripheral neuropathy, peripheral neuropathy, MND, myopathy, peripheral neuropathy, syringomyelia, Charcot-Marie, cervical spondylitis, cervical rib. Fasciculation is contraction of the fascicle. Fascicle means group of muscle. It is visible. Fascicle, visible group of muscle. Fascicle, visible group of muscle. And fibrillation is contraction of a single muscle fiber. Fiber fibrillation is contraction of a single muscle fiber fibrillation. Fascicle, visible, and group of muscle. Fascicle visible is group of muscle, and fibrillation is single muscle fiber. For fibrillation single muscle not visible, diagnosed by EMG. Fascicle visible group of muscle. Cause of fasciculation: MND, Charcot-Marie tooth disease, spinal muscle atrophy, radiculopathy, syringomyelia, peripheral neuropathy, metabolic thyrotoxic myopathy, anticholinergic OPC poisoning. What are the neurologic non-metastatic syndrome of malignancy? Neurologic non-metastatic syndrome. What are the neurologic non-metastatic syndrome of malignancy? It is motor neuron disease, mononeuritis multiplex, Eaton-Lambert. Non-metastatic syndrome. Say there is no metastasis. MND, neurologic, but non-metastatic syndrome of malignancy, neurologic. Eaton-Lambert. Progressive multifocal PML. Mononeuritis multiplex. These are the neurologic non-metastatic symptoms. And that's all about the MND. Hope you enjoy.